Hello and welcome to Chronic Pain Tips for Patients, a podcast designed to help patients better understand chronic pain conditions and the treatments that may be available. I'm Dr. Yuri Martins. I'm a board certified chronic pain physician in the St. Louis and Southern Illinois area, and today we're going to talk about a very common but often misunderstood cause of neck and low back pain: facet joint pain. We'll also discuss two procedures that are frequently used in the evaluation and treatment of facet-related pain: medial branch blocks and radiofrequency ablation, also called RFA. By the end of this episode, I hope you understand what facet joints are, how they can cause pain, why medial branch blocks are usually done before radiofrequency ablation, what happened during these procedures, and what risks patients should know about. As always, this episode is for general education only. It should not replace direct medical advice from your own physician or other qualified healthcare professional. So, what are facet joints? Back and neck pain can come from many different structures. It can come from discs, nerves, muscles, ligaments, joints, and sometimes a combination of these structures. One common source of spinal pain is the facet joints. Facet joints are small joints located in the back part of the spine. They connect one vertebra to the next and help guide movement. You have facet joints in the neck, mid back, and low back. Like other joints in the body, facet joints can become painful. They can be affected by arthritis, inflammation, injury, repetitive stress, or age-related degeneration. A useful way to think about facet joints is to compare them with other joints, like the knee or hip. These joints can develop arthritis and become painful. Facet joints can also develop arthritis and become painful, but because they are located deep in the spine, patients may not always know that these joints may be contributing to their symptoms. What does facet joint pain feel like? Facet joint pain is often described as deep, aching pain. It is usually what we call mechanical pain, which means it changes with posture and movement. For example, facet joint pain in the low back may become worse with standing, walking, twisting, or bending backward. Some patients feel better when sitting or leaning forward. In the neck, facet joint pain may cause neck pain, shoulder blade pain, headaches, or pain that travels toward the back of the head. In the low back, facet joint pain may cause pain across the low back, buttocks, hips, or thighs. One important point is that facet joint pain usually does not behave like a classic pinched nerve. A pinched nerve may cause sharp, shooting pain, numbness, tingling, or weakness traveling down the arm or leg. Facet joint pain may refer pain to nearby areas, but it usually does not follow a clear nerve root pattern. When pain is mainly located in the neck or back and does not clearly travel down the arm or leg, doctors may call it axial pain. Facet joint pain is one possible cause of axial neck pain or axial low back pain. Many patients are surprised to learn that facet joint pain cannot be diagnosed reliably by MRI alone. An MRI may show arthritis in the facet joints, but that does not always mean those joints are causing pain. Some people have significant arthritis on imaging and very little pain. Other people may have pain from facet joints even when imaging findings are not dramatic. This is why the diagnosis requires a careful history, physical examination, review of imaging when appropriate, and sometimes diagnostic procedures. The main diagnostic procedure used for facet joint pain is called a medial branch block. What are the medial branch nerves? The facet joints are supplied by small nerves called medial branch nerves. These nerves can carry pain signals from the facet joints to the spinal cord and brain. The medial branch nerves do not control the major muscles of the arms or legs. Their main role in this context is to carry pain signals from the facet joints. Because of this, These nerves can be used as targets for diagnosis and treatment. That brings us to medial branch blocks. What is a medial branch block? A medial branch block is a diagnostic injection. The goal is to temporarily numb the medial branch nerves that carry pain signals from the suspected painful facet joints to your brain. This is very important. A medial branch block is not usually intended to be a long-term treatment. It's basically a test. During the procedure, a small amount of local anesthetic is injected near the medial branch nerves. If the patient's usual pain improves significantly for the expected duration of the anesthetic, that suggests the facet joints are likely an important source of pain. For example, if a patient usually has low back pain when standing or walking, and after the block they can stand or walk with much less pain, that is useful diagnostic information. Why are two medial branch blocks often required? Many insurance companies require two positive medial branch blocks before approving radiofrequency ablation. There is a reason for this. A single block can sometimes give a false positive result. A false positive result means the patient feels better after the injection, but the facet joints may not actually be the main source of pain. Pain is complicated. Placebo effects, temporary change in activity, spread of local anesthetic, and other factors can influence how a patient feels after one injection. By repeating the block on a different day, we increase confidence that the diagnosis is correct. The first and second blocks use different local anesthetics. One medication may last a shorter time and another may last longer. The goal is to see whether the patient gets meaningful relief during the expected time window. This is why patients are often asked to keep careful track of their pain after each block. The most helpful information is not just "I feel better." The more helpful questions are: how much better was my usual pain? How long did the relief last? Could I do activities that normally cause pain? Was the duration of relief consistent with the medication used? Patients should be as accurate and honest as possible about the amount of relief. If the blocks do not provide much relief, radiofrequency ablation is much less likely to help. How is a medial branch block performed? Medial branch blocks are usually done in an outpatient procedure room. This means patients do not need to be admitted to the hospital. The procedure is typically performed using X-ray guidance, called fluoroscopy. For lumbar medial branch blocks, the patient usually lies face down on a procedure table. For cervical medial branch blocks, the position may vary depending on the level and technique used, but the goal is to position the patient safely and allow accurate X-ray visualization. The skin is cleared with a sterile solution, sterile drapes are placed, a timeout is performed. During the timeout, the healthcare team confirms the patient's name, date of birth, the procedure, and the correct location and site. Then, local anesthesia is placed in the skin and deeper tissues. Patients usually feel a small poke and a burning sensation from the numbing medication. Using fluoroscopy, the physician guides small needles to the correct bony landmarks where the medial branch nerves are located. Once the needles are in position, a small amount of local anesthetic is injected near the nerves. After the procedure, the patient is monitored briefly and then discharged home. The most important part happens after the patient leaves. The patient needs to observe how much pain relief occurs and how long it lasts. What is radiofrequency ablation? If the medial branch blocks are positive, the next step may be radiofrequency ablation, also known as RFA. Radiofrequency ablation uses heat generated by radiofrequency energy to interrupt pain signals traveling through the medial branch nerves. The goal is to reduce pain coming from the facet joints for a longer period of time. RFA does not remove arthritis. It does not reverse degeneration. It does not make the spine young again. Instead, it treats pain by targeting the small nerves that carry pain signals from the painful facet joints up to your brain. Because nerves can regenerate over time, the relief from RFA is usually not permanent. Many patients experience relief for several months, commonly around 6 to 12 months. Some patients have shorter relief and others have longer relief. When pain returns and the first RFA was successful, the procedure can often be repeated. How is radiofrequency ablation performed? Radiofrequency ablation is also performed in a procedure room using fluoroscopy. The skin is also cleaned with a sterile solution, sterile drapes are placed, the physician numbs the skin and deeper tissues with local anesthesia. In the vast majority of cases, local anesthesia is used. Some patients may receive light sedation depending on the situation, the physician's judgment, and the patient's medical condition. However, heavy sedation is usually avoided because the patient feedback can be important during the procedure. Using fluoroscopy, the physician guides a specialized radiofrequency needle to the appropriate target. These targets are based on the location of the medial branch nerves. Before creating a heat lesion, the physician typically performs sensory and motor testing. So, what are sensory and motor testing? Sensory and motor testing are safety and positioning checks performed before the ablation. During sensory testing, a small electrical signal is used to see whether the needle is close to the target nerve. The patient may feel tingling, pressure, buzzing, or similar sensation in the expected area. During motor testing, a different electrical signal is used to make sure the needle is not too close to nerves that control important muscles. The physician watches for muscle responses. A small twitch in the nearby back or neck muscles may be expected, but a strong stimulation traveling down the arm or leg would be a warning sign that the needle may be too close to a spinal nerve. In that case, the needle position would need to be adjusted. Once the position is confirmed, local anesthetic is usually injected through the needle to make the ablation more comfortable. Then, the radiofrequency lesion is created by heating the tissue around the needle tip for a set amount of time. The procedure may be repeated at several nearby levels because each facet joint is usually supplied by more than one medial branch nerve. What do patients feel after medial branch blocks or radiofrequency ablations? After medial branch blocks, patient may have temporary soreness at the injection sites. The key task after the block is not to rest all day and forget about the test. The key task is to monitor pain relief during normal activities that usually cause pain. After radiofrequency ablation, patients may have soreness, aching, or temporary increase in pain for several days. Some patients improve quickly, others need a few weeks before they can judge the full benefit. The delay can happen because the treated nerve and surrounding tissues may be irritated at first before the longer term pain relief becomes clear. Some patients may also notice temporary numbness, sensitivity, burning discomfort, or sunburn like feeling in the treated area. This is sometimes called neuritis. Most of the time, this is temporary, but in some cases, it can last longer. So, what are the risks of medial branch blocks? Medial branch blocks are generally considered low-risk procedures when performed with image guidance, but no procedure is risk-free. Possible risks include bleeding, infection, allergic reaction, temporary worsening of pain, vasovagal reaction, and temporary numbness or weakness. A vasovagal reaction is a fainting type response that can happen with needles, pain, anxiety, or medical procedures. Another issue is intravascular injection, which means medication enters a blood vessel. This is one reason fluoroscopy and contrast injection may be used. When intravascular injection happens during a diagnostic block, the local anesthetic may be carried away from the target nerve. That can produce a false negative result. In other words, the block may appear not to work, even though the facet joint could still be a pain source. Bleeding around the needle site is usually minor. Serious bleeding is rare. Infection is also rare, but possible with any procedure that passes a needle through the skin. Nerve injury is uncommon, but it's part of the informed consent discussion. In the cervical spine, the anatomy is much more delicate because the spinal cord and important blood vessels are nearby. This is why careful technique and image guidance are especially important. What are the risks of radiofrequency ablation? Radiofrequency ablation also has a favorable safety profile overall, but it has its own risks. The most common issue after RFA is temporary post-procedure pain. This may feel like soreness, burning, aching, or increased pain around the treated area. For many patients, this improves over days to weeks. Other possible risks include bleeding, infection, allergic reaction, temporary numbness, temporary neuritis, and temporary worsening of pain. Rarely, nerve injury can occur. For lumbar RFA, one consideration is that the medial branch nerves also supply small stabilizing muscles of the spine, especially the multifidus muscle. Because of that, RFA may cause some degree of denervation of these small muscles. Research is still evolving on how clinically important this is. Some studies suggest that changes in the multifidus muscle can be seen after RFA, but there is no clear evidence that this routinely causes spinal instability. This is one reason the procedure should be used only when diagnostic blocks support facet-mediated pain. For cervical RFA, there are additional considerations. Temporary dizziness, imbalance, numbness, or sensitivity can occur, especially when treating higher parts of the neck. Rare but serious complications have been reported, including vertebral artery injury, stroke, spinal cord injury, and dropped head syndrome after extensive bilateral multilevel cervical RFA. These severe complications are very uncommon, but they are important to discuss because the neck contains critical nerves and blood vessels in a relatively small space. To reduce risks, pain physicians use careful fluoroscopic guidance, appropriate needle position, sensory and motor testing, and cautious selection of levels. In some cases, especially in the cervical spine, the physician may avoid treating too many levels at one time or may stage procedures on different days. So, why patient selection matters? Radiofrequency ablation works best when the pain generator has been identified correctly. This is why medial branch blocks are so important. If a patient has strong pain relief after two properly performed medial branch blocks, the chance of benefiting from an RFA is higher. If the blocks do not help, RFA is much less likely to be useful. It is important for patients to be truthful and accurate about the amount of relief they had from the blocks. The amount of relief from RFA often corresponds to the relief experienced during the diagnostic blocks. If the blocks only provide minimal relief, the RFA is unlikely to provide dramatic relief. It is also important to remember that not all neck or back pain is facet joint pain. Some patients have pain from discs, sacroiliac joints, spinal stenosis, nerve compression, muscle dysfunction, hip disease, or other causes. Many chronic pain patients have more than one pain generator. A good treatment plan starts with a careful history, physical examination, review of imaging when appropriate, and a discussion of the patient's goals. So, what RFAs can do and cannot do? Radiofrequency ablation can reduce facet-mediated pain and improve function in properly selected patients. It may help patients stand longer, walk further, sleep better, participate in physical therapy, and reduce reliance on pain medications. But RFA does not cure arthritis. It does not reverse aging. It does not prevent every future episode of pain. It is best understood as one tool that may reduce pain enough to help patients move better and participate more fully in daily life and rehabilitation. For many patients, that improvement can be meaningful. Facet joint pain is a common cause of chronic neck and low back pain, but it can be difficult to diagnose based on symptoms or imaging alone. Medial branch blocks can help determine whether the facet joints are truly contributing to the pain. If two diagnostic blocks provide significant temporary relief, radiofrequency ablation may be an option for long-lasting pain reduction. As with any procedure, the decision should be individualized. The potential benefits must be weighed against the risks, the patient's anatomy, medical conditions, medications, imaging findings, and overall treatment goals. If you have chronic neck or low back pain and have been told you may have facet joint pain, a pain physician can help determine whether medial branch blocks and radiofrequency ablation are appropriate options for you. To learn more about chronic pain conditions and treatment options, visit my website at www.ycmartins.com or contact my clinic to schedule an evaluation. Thank you for listening to Chronic Pain Tips for Patients. If you like this content, please follow the podcast or leave a comment. Again, I'm Dr. Yuri Martins. Until next time, take care of yourself and keep learning about your pain. This podcast is for educational purposes only and should not be used as substitute for direct medical advice from your doctor or other qualified healthcare provider. Any views, thoughts, and opinions expressed in this episode are solely those of the author and do not reflect the views, opinions, policies, or positions of the author's employer, company, institutions, or others associated parties.